part. When the Q&A session starts, then you might raise hands, and Mr. Stylianidis, who is going to moderate the discussion part, is going to offer the floor so that you state your questions. So before we begin, I would also like to take the pleasure to present Mr. Stylianidis, of course, who is with us today. Mr. Stylianidis is Professor of Social Psychiatry, Psychoanalyst, Group Analyst, Founder and Honorary President of EPAPSI, and will coordinate today's discussion. And Mr. Galanis, who is the President of the Board of EPAPSI, and will address an initial salutation. So, Dimitris, the floor is yours.
Thank you, Angeliki. Dear colleagues, dear friends, dear Professor Saraceno, today I feel truly honored and proud that one of the most significant advocates of modern community psychiatry, Professor Benedetto Saraceno, has accepted the EPAPSI's invitation and is standing among us to deliver an influential lecture. We're undergoing a very turbulent period with major socio-political and economic challenges, period of high uncertainty that has affected our lives at all levels. I believe that we just have started to seriously access the effects of the two-year pandemic at a social and individual level, and initiate open dialogues on important mental health issues. I look forward to Professor Saraceno's lecture, trusting that it will initiate fruitful and much-needed discussions, inspiring us to visualize and plan collective efforts for a better mental health care today and in the future. Kiki.
So, thank you, Mr. Galanis. Mr. Zoirapti, the Deputy Minister of Health, we had the honor of her paying a visit to the day center of EPAPSI, and she would like to, she's honoring us with her attendance in today's lecture, and she would like to address a formal salutation.
Dear all, I would like to thank you for inviting me to today's event regarding the current challenges of community psychiatry, and I would like to congratulate EPAPSI for organizing the event, and especially EPAPSI Chairman, Mr. Stylianidis, and EPAPSI President, Mr. Galanis, for choosing such a contemporary and interesting subject, as well as EPAPSI's scientific and other personnel for their contribution on mental health service in our country. It is an honor for me to participate in this open lecture with Dr. Saraceno, Secretary General of Lisbon Institute of Global Mental Health and ex-director of the WHO Department of Mental Health. Dr. Saraceno's scientific knowledge and experience in the foundation of psychiatry reform, psychosocial rehabilitation and empowerment of recipients and the community is undoubtedly a valuable scientific contribution. But at the same time, his work serves as a reference point for shaping mental health policies and applying community psychiatry principles. I am sure that this lecture today will also enlighten us on the application of community psychiatry in times of crisis, such as the one we are experiencing now. The pandemic highlighted the importance of mental health as a key pillar of overall well-being as well as public health. Before we knew it, a new crisis hit us, the war in Ukraine. Once again, we have to work very hard and together to provide high-quality mental health services to all citizens, including our fellow citizens, now refugees from Ukraine. Equal and overall access to mental health services can only be achieved by developing community-based and specialized facilities. Our Prime Minister in Greece, Kyriakos Mitsotakis, foresaw the need to focus on improving the general population's mental resilience and ensuring universal accessibility to mental health services. Also, He created a portfolio dedicated for mental health and addictions in the Ministry of Health, which I had the honor to be assigned. Since the beginning of the pandemic, the Ministry of Health, in alignment with the WHO's principle, leave no one behind, has taken a series of steps to address the needs of the general population with a focus on the most vulnerable groups. The principle takes on a new meaning with the war on the spotlight. Among others, we increased public funding in mental health, and for the first time in Greece, the funding of the social cooperatives for mental health that we introduced in the regular budget of the Ministry of Health, ensuring the right of the mentally ill to reintegration and vocational rehabilitation. We are providing also psychosocial support to adults, children, and adolescents across the country, including the isolated areas, through hotlines, telepsychiatry services, and digital tools. In order exactly to adapt to the needs of the refugees from Ukraine, we extended the operation of our psychosocial support helpline 10306 in Ukrainian and Russian. Furthermore, we are developing mental health facilities in the community, residential facilities, mobile units, day centers for the psychosocial support of different target groups across the country, with a focus on children, adolescents, and the elderly. Also, mobile units are a key point to our planning, given their own low cost, flexibility, and ability to intervene in emergency situations across the country. To support all of the above, we secured 55 million euros from the Recovery Resilience Facility. Also, early intervention services in psychosis were legislated for the first time and are now under development. We are also developing a digital map so that the citizens can identify all the available in their area. And also, we are creating collaborations and synergies with national and global actors and organizations such as WHO Europe, UNICEF, and other ministries and local authorities. We are focusing now on quality of care and patient safety, and we recently inaugurated the WHO Athens Quality of Care Office towards achieving the highest level of well-being in alignment with the European Programme of Work 2020-2025 United Action for Better Health. Our vision is to shape our mental health network so everyone can achieve optimal health through equal access to people and community-centered quality services, with zero tolerance to any exclusion. Thank you very much.
I would like to kindly remind our participants to keep their microphones off throughout the duration of this online lecture, and offer, of course, the floor to the founder and honorary president of EPAPSI, Mr. Stylianidis, who will introduce our distinguished guest and talk about the importance of this unique initiative. Mr. Stylianidis.
Thank you. Καλημέρα σε όλους, συνάδελφοι. Good morning to everybody, and it's a great honor, a pleasure for me to introduce my distinguished colleague and friend, Benedetto Saraceno, since many, many years. Allow me to mention some key points of his brief CV. Otherwise, his CV is huge. We didn't have time to present all his CV. So Professor Benedetto Saraceno is actually the Secretary General of the Lisbon Institute for Global Mental Health. From 1999 to 2010, has been the Director of the Department of Mental Health and Substance Abuse at the World Health Organization, Geneva. And from 2007 to 2008, he was also Director of the WHO Department of Non-Communicable Diseases. He has been Gulbenkian Professor of Global Health at the University Nova of Lisbon from 2010 to 2018, and still is the co-director of the Lisbon International Learning Program at Mental Health Policy and Services, Lisbon Institute of Global Mental Health in Portugal. He has been one of the commissioners of the Lancet Commission on Global Mental Health. He has been from 2012 to 2017, the head of the steering committee of the Gulbenkian Foundation Global Mental Health Platform. From 2010 to 2014, Professor Saraceno has been the chairman of the Human Rights in Mental Health. For 10 years in the past, from 1986, years that I met Professor Saraceno in Paris, from 1996, from 86 to 96, Professor Saraceno served as head of the Laboratory of Epidemiology and Social Psychiatry at the Mario Negri Institute for Research in Milan. During many years, he has served as advisor to WHO and to the Pan American Health Organization, PAHO, and from 94 to 96, he was also the president of the World Association for Psychosocial Rehabilitation, WHO PR, WAP. Saraceno has received several honors: Honorary Fellow of the Royal College of Psychiatrists of UK, Fellow Swiss School of Public Health in Switzerland, Honorary Doctor of the Birmingham City University of UK, and Honorary Doctor of the Universidade Nova de Lisboa in Portugal. Saraceno has published 7 books, translated in different languages, in critical mental health issues, and more than 200 scientific papers in high-level international journals. And allow me to say, Benedetto, that Professor Saraceno is also a writer the last years and a discreet poet. Thank you for being with us, Benedetto. The floor is yours. After your presentation, we hope that we will generate a fruitful discussion concerning the general topics and also the national topics in Greece in this period. Thank you.
Well, in my country, there is a saying which says that when too many positive words have been said about a person, the next evening or night, a wolf will come to eat me, to punish me of being too honored by my friends in Greece. I am very flattered and honored by the salutation of the Deputy Minister of Health, which is uncommon. A part of being an honor to me is a privilege for you as EPAPSI to have the attention and the time of such a senior member of the government who made an effort to be present, to say some words, and I understand to visit in the recent days one of your facilities of EPAPSI in Athens. All this is uncommon in any country, having this kind of attention from a person sitting in the political environment. I want to thank you, Dimitris Galanis, for being with us, for inviting me in his capacity as president of the board of EPAPSI. And of course, thanking Professor Stylianidis is not easy for me, because I should give up to any formal wording. Stelios is a brother for me, is a friend. Since so many years, we have shared ideas, discussion, controversies, disagreements, but our friendship is solid. And I have a tremendous admiration. And I'm saying this not to be nice. I think that Stylianidis is the founder of epilepsy, is the honorary president of the board. But all this doesn't say the substantial part of the story. His tremendous love for epilepsy that made him a tremendous endurance in overcoming different type of crises. I remember, I know Stylianidis since so many years. Epilepsy is like a manic depressive patient, was going up and down, periods that were rich financially and rich of ideas, of commitment, of intelligence, and period where there was no money, and maybe there was not such a motivation, not such good idea, not such good enthusiasm, not such good commitment. But never Professor Stylianidis gave up, never said, bye-bye, I'm fed up. He was never fed up, and he shows an incredible endurance in keeping the baby, and the baby now is an adolescent, and now is an adult. And I think the present situation of epilepsy looks as an expansion time, an expansion period, which is very positive and will bring money, expansion, but also challenges that are more and more complex to be dealt with. Having said so, I will present some ideas and some considerations about community mental health. Let me share the screen. I hope this is now visible for you. Do you see the screen? Do you see the screen?
Yes, it's okay. It's fine.
Thank you very much. So, community psychiatry or community mental health. We will go into this also in this semantic discussion about what is psychiatry and what is mental health. But provisionally, let's say that there are challenges posed to community psychiatry. Well, I start my presentation with two preliminary questions. Does community exist as we have imagined it during the last 100 years? We constantly talk about community mental health, community work, community mental health services. So the word community is inflated. We use community so many times during our day, but I think we have to ask ourselves whether the notion of community we had 50 years ago is the same 30 years ago and is the same today and will be the same tomorrow. That's my first preliminary question. And my second, we use as they were synonymous, psychiatry and mental health. I am not sure that they refers to the same notion. So it will be important to clarify once forever, what do we mean when we talk about psychiatry and when we talk about mental health? these two preliminary questions will be not addressed specifically, but they will be cross-section of the entire presentation. And at the end of the presentation, I will try to give two short answers to these two preliminary questions. The Lancet Commission on Global Mental Health and Sustainable Development published in 2018 one document that I consider a seminal document providing the state of the art of the best evidence and knowledge we have in mental health and in global mental health. First of all, we know that the global burden of disease to mental and substance use disorders has been changing during the past 25 years, from 1990, when for the first time the notion of burden of disease was introduced by WHO and by the World Bank, and 2015 and 16, 17, till now. You see that the red line in the slide means the global burden of mental problems in rich countries, in high-income countries, while the blue at the bottom of the graph shows the low-income countries, and the green C in the middle shows the average, the global. And you may see that overall there is an increase, which is not so evident in the last years of the high-income countries, but generally speaking, we can see that mental disorders are increasing. The burden of mental and substance use disorders increased nearly 50% in the past 25 years. And these disorders now account for 1 in every 10 years of lost health globally. So the burden, the problem is there, is still there, and even if it's worse. And global health and global mental health have to do with poverty. We know that. We have enough evidence showing the links between extreme poverty and relative poverty and mental health. I make a distinction. Extreme poverty is one thing. Relative poverty is being poor among the rich. For a person who is an immigrant coming to Athens or to Milano or to Paris means being poor among the rich. This is relative poverty. While being in a remote village of Nepal or in a remote tribe of Africa probably has to do with absolute poverty. Both conditions have some links, important links, with mental health. Mental health has to do with conflicts and forced migration. We know that, you know that, because I am aware that EPAPSI is committed to migrants coming to Greece. So conflicts and migrations are increasing. When I started my career in WHO in 1996, in the world, we had 14 million of refugees. Nowadays, we have 60 million of refugees. And I am not Methuselah. So when I started my career, was not 2 centuries ago, was some years ago. So in few years, the burden of conflict, forced migration due to poverty or to ecological crises like earthquake or flood or other agricultural problems, has increased substantially. Violence has to do with mental health, personal violence, domestic violence, violence on women, violence on children, and collective violence. So all these are social determinants of ill mental health are hard hitting, mostly in low-income countries, poverty, social inequalities, violence, migration, refugees, conflict. The environment today is not at all conducive of better mental health, but of worse mental health. If you look at the problem is increasing, as I am showing you, but if you look at the expenditure, so if you compare in dark blue the years lived with a disability due to mental problems, and in light blue, the total of the health spending, a fraction of the total of health spending devoted to mental health, namely the percentage of money spent by government for mental health from the envelope of health in general, you see that the years lived with disability in on the right of your slide, high-income countries, upper middle income countries, lower middle income countries, low-income countries. The years lived with mental disabilities are not the same. In some countries, upper middle is highest. Some other group of countries are less relevant. But if you look at the money spent for mental health as the fraction of the money spent for health, you see that this is ridiculous. So against 25% of the years lived with disability, you have a little bit more than 0%, let's say around 0.5% of the budget of health is devoted to mental health. A little bit better in lower middle income countries, similarly in upper middle, a little bit better in high income countries. To give you a more concrete example, imagine United Kingdom, which is probably the country that spent the most in mental health, spent around the 12% of the general health budget for mental health. On average, in Europe, the expenditure is less than 6%. Imagine in low-income countries, can be less than 0.5%. So, problem is big, money is little. And if you look at the international assistance for development spent for mental health, you see that millions of dollars spent for HIV/AIDS, huge amount, much less for maternal and neonatal health, a little bit less for malaria, a little bit less for tuberculosis, and you don't see anything for non-communicable diseases, namely cancer, cardiovascular, respiratory, and diabetes. And you don't see anything for mental and substance use disorder. Of course, some money of the development assistance internationally is spent, but it's so little that in the graph is invisible. So conclusion, I am saying, I'm giving you two information. On one hand, the burden is increasing, and on the other hand, the available money to address the burden is insufficient, low, scandalously low. The other scandal, apart of the lack of funds, is the failure of humanity that still is and still characterizes the mental health settings, or better, the psychiatric settings. All these pictures, including those of the man in chain, are taken in psychiatric hospitals. So in places that are supposed to be places for therapy, for treatment. There is a rhetoric here saying, well, but these terrible human rights violations occur in remote, poor, miserable countries. So it is very common to see when people show pictures of human rights violation in psychiatric hospital, to see always systematically people from India, Black people from Africa. This is very reassuring for us, the Europeans, because we can say, well, this is terrible, but this is not me. This is occurring to them, the Africans, them the Indian, the Chinese, the poor. But you see, in the middle of the slides, a white man in a cage, and this is a European picture. So human rights violations occur everywhere, including Europe, including Greece, including Italy, including Germany, including France. We tend to deny this, but the truth is that even if people are not in chain in your Greek psychiatric hospitals, still the psychiatric hospitals are breaking the United Nations Convention on the Rights of Persons with Disability, which has been signed and ratified by Greece, by Italy, by France, by Germany, and systematically is violated. So we need to refrain, because the world has simply not responded to the evidence, technical, scientific evidence, and moral evidence. All countries are developing when it comes to mental health. There are no developing countries and developed countries. This is probably true when we talk about heart surgery. Of course, heart surgery or sophisticated surgery is different in poor developing countries and in rich developed countries. But mental health often is very similar in poor and in rich, in developed and in developing countries. Of course, we need to go beyond addressing the treatment gap to take seriously prevention. There are effective prevention strategies. Suicide prevention is possible. We have examples in countries where we have been able to reduce by 7, 10, 15% suicide rate. So it is possible. Suicide prevention is possible. Alcohol abuse prevention is possible. Child and adolescent mental problems are preventable. Not all is preventable, of course. You can't prevent schizophrenia. No, you can prevent schizophrenia relapse. It is possible to do more and better. But we have to understand that the mental health is not working in a categorical dimension, black and white. You have a cancer or you don't have a cancer. You have a virus of SIDA or you don't have a virus. You cannot have a little bit of virus. You can't say this morning, I have a little bit of cancer. It's a nonsense. So in medicine, very often, the dimension is categorical. Yes, no, black, white, case, non-case. That's not the reality of mental health. Mental health is distributed in a dimensional way across an horizontal line, going from positive mental health to mental distress, to mental disorder, to disability. And you may navigate across this line, changing your position from disabled to disorder, from disorder to distress, from distress to recovery. So this possibility is quite common in mental health. And this means that you move from promotion to prevention to remission to recovery and rehabilitation. But all what I'm saying is somehow banal, trivial, common, obvious. But the problem is, where is the money? The money is concentrating only on mental disorder. No money for prevention, no money for promotion, no money for serious psychosocial rehabilitation of long-term chronic mentally ill patients. They are still doing ashtray, puppets, stupid things in psychiatric hospitals. This is not rehabilitation. Rehabilitation is building citizenship, is reintegration, is social inclusion. There is money for that? No money for that. So the money is concentrated in one fraction of this horizontal line. And within this fraction is hyper-concentrated for acute cases. So the money goes to hospital. The money goes to hospital for acute patients. There is no money for chronic patients. They abandon. And there is no money for rehabilitation, serious rehabilitation. No money for prevention, no money for promotion. We need to build a mental health strategy based on rights, the right to be protected, the right to receive care, the right to dignity and freedom. And we have the convention setting those rights. There are some aspects of mental health care that are somehow pioneering. Of course, there are many places where we are reconfiguring care from hospitals to communities. Epilepsy is a fantastic example of reconfiguring care to community. But allow me a provocative question. Has been epilepsy able to reconfiguring from hospital to communities? or there is a parallel system, a community mental health system, which sometimes is excellent, but the perpetration and the continuation of the traditional asylums and psychiatric hospitals that remain untouched. That's the problem. Involving patients and family in planning and providing services. This is also important, to move from a very condescending attitude we, the mental health professional, we have with users. Now, it's very often you see in a conference that there is one user that is showing and people are applauding, clapping, fantastic. No, that's not empowerment of users. The empowerment of users means that users have the power to be part of the decision-making process. How many hours is the mental health service open? They are excluded from this decision. How is the food? How is the liberty? How is the cleaning of the bathroom? How is the room given to people in hospitals? How much is evaluated and assessed the side effects of psychotropic drugs, sorry. In this area, we need the empowerment of service users. It's not enough to celebrate the rhetoric of, oh, here there is the user that talks 3 minutes and people clap, clap, clap. That's not power. That is show. We don't need show with users. We need power to users. We need a person-centered approach addressing comorbidities. We need to incorporate social intervention alongside psychological, pharmacological intervention. We should stop thinking to social determinants just in the equation of the etiological model. Of course, we know that being poor, low educated, excluded, migrants, single mother, are all social determinants affecting mental health. But it's not enough to know that, to say that, to do epidemiological study showing the connection between social determinants and mental health. What we need is what kind of intervention we do to reduce the impact of social determinants. And don't accept the excuse very often used by some psychiatrists saying, but we cannot change poverty or war or conflict. Of course, we are not so stupid. We are not asking you as a mental health professional to stop war between Russia and Ukraine. We are not asking you to resolve the problem of migrants. What we are asking you is, when you are treating a patient, that there are personal micro-social determinants that can be changed. There is a nice example in a recent paper published in the American Journal of Psychiatry, where it says in a peripheral area of New York, imagine that there is a Black woman who is a single mother, has no partner. She's very poor, and she has 3 children, one 10-year-old, the other 7-year-old, and the other 3-year-old. She lives with these children. She's poor, she's Black, and she's living squatting in a very miserable apartment. Epidemiology tells us that she has 400 times the chances of a severe depression, more than another woman who is not in those disadvantaged conditions, who is not exposed to those social determinants. Now, imagine you are the director of the community mental health service in the area of this woman. You can go, knock the door, and to say, hey, madam, I am Dr. So-and-so. I am the head of the mental health service in the nearby. We are doing psychotherapy. We can see you. We can do a diagnosis. We can give you medication. If you are depressed, you can come. We can give you a rendezvous, an appointment. Or you can go, knock the door and say, hello, madam. I am the director of the community mental health service in the nearby. We have discussed it with the mayor of the city, and he is saying that you will receive 3 times per month vegetable and fruits for free for your children. And then we have organized that every morning there is a transportation taking your children to school, and you have not to go in 3 different schools with them. And on Friday, we can organize a babysitting for you of 3 hours, so you can go and finally breathe without your children and attend the meeting of other women that are meeting and discussing their own problems. Before I go, madam, this is my address. I have a community mental health service where we can give you a diagnosis if you want medication or psychological support. Bye-bye. These 2 different approaches mean that you may put social determinants at the center of your intervention or at the periphery of your intervention. There are innovations. Yes, of course. We have now more and more psychosocial intervention delivered by non-specialist providers, the famous task shifting. We have digital tools for the workforce. There are interesting experiences done in India through using mobile phone to support patients in remote rural villages. There is an optimal mix of services for the full spectrum of problems. There is community engagement to increase demand and accountability. Innovations are there. Yes, they are. But there are barriers that prevent innovations. Mental health resources are centralized in and near big cities and in large institutions. We need extra funding to shift to community-based service. There is a terrible resistance by mental health professionals and workers whose interests are served by large psychiatric hospitals more than by community services or by beds for acute patients in general hospitals. There is a second barrier, which is the tremendous difficulty in integrating mental health care in primary health care services. Primary care workers often are overburdened and they don't want to operate in the mental health field. There is a lack of supervision, especially support. We offer training, but we don't offer supervision. And supervision is more effective than training. Supervision of a single case to a GP, to a general practitioner, is much more effective, has much more impact than a 6 hours training. And in some countries, there is lack of continuous supply of psychotropic drugs in primary care. That's not, of course, the case of Greece. The third barrier, and the investment still is or in primary care or in tertiary care, but there is not very much investment in the second level of care, which is the community mental health. Community mental health care implies prioritizing the development of specialized, community-based, multidisciplinary mental health and the opening of psychiatric wards in general hospital, this is crucial. If you want an effective community mental health service functioning, you should give to this community mental health service in the community the possibility for acute patients being hospitalized, not in the asylum, not in the psychiatric hospital, but rather in beds in general hospitals. These are interlinked: community mental health service and acute and beds for acute cases in general hospital. This is the receipt to decrease the admission in psychiatric hospitals. There is sufficient evidence proving that community mental health teams increase user satisfaction, quality of life, increase met needs. Yes. Community mental health care improve adherence to treatment and identify and treat more often and earlier relapses. There is evidence that community mental health care improve continuity of care. So we don't lack evidence to defend, promote, and strengthen community mental health care. But what is important is that community mental health care cannot survive in a vacuum with still terrible asylums, with no beds in general hospitals. A community mental health care is a service able to provide treatment, care to severely mentally ill people, providing, coordinating psychosocial rehabilitation. Rehabilitation is not occurring in psychiatric hospital. This is a joke. Psychosocial rehabilitation is life skills occurring in the community where patients live, supporting users and their family, including at home with domiciliary visits, coordinating referral and back referral with the primary health care doctors, training, supervising primary health care doctors, and coordinating inpatients activity in general hospital. So you see that the center, the orchestra conductor of the mental health system in a country is the community mental health center. Of course, it remains the unsolved problem of institutions. I think that there is something to be clarified once forever. People, many people, still believe that deinstitutionalization means pushing chronic patients out from asylum. This is not deinstitutionalization. The main element of deinstitutionalization is not the exit door of the hospital, but the entrance door of the hospital. Because if you are so good to find alternative solution for patients moving from psychiatric hospital to community, protected apartment, halfway houses, facilities, whatever, but you don't make any intervention on the entrance door, your hospital will forever still be full. It's like empty a vase from water, but you leave the water entering in the vase and you don't operate in the entrance of the vase, but only on the exit. If you take the example of Italy, in 1979, when the law of reform that closed down psychiatric hospitals started, July 1979. In Italy, there were 99 asylums and 100,000 patients. 15 years later, there were 0 asylums and 0 inpatients. The enemies of the reform used to say, well, they all died. They committed suicide. They are in prisons. They killed the mother. So it was a disaster, the reform, the enemies. The friends of the reform were lying as the enemies. They were saying, oh, fantastic. All these people are now fantastically located in community services, in protected apartments. We did an epidemiological study. You know that more than half of those 100,000 simply died by natural death, simply because they were 80 when the reform started. So paradoxically, if you stop the entrance of a psychiatric hospital and you do nothing, in 25 years, the hospital is empty. Of course, it's a very cynical strategy. You leave the people in the hospital, you do nothing, but there are no new patients. Of course, deinstitutionalization means doing at the same time different contemporary actions. The program IDEAL, which stands the acronymous for I, increasing community care for those who can leave the psychiatric hospital. Not all can leave the psychiatric hospital. Many can, but not all. There will be a program which aims to increase community care for those who can leave the hospital. Fine, let's say 60% of the population of the hospital. There is another contemporary program run by another group of people, which is aiming at decreasing admission in psychiatric hospital. No new cases. New cases acute goes in general hospital beds. And this is the second group. Then there is a third group, because the first group take care of a big fraction leaving the hospital, deinstitutionalizing. Another group operate preventing new admissions. Fantastic, no new cases. But there is a fraction that is remaining in the hospital. They are very old, they are very chronic, they are very ill. They have no family, there are no solutions. You have to have a third group aiming at enhancing the quality of care and the rights of those who stay in psychiatric hospital. You should assess periodically the process, and you should learn from peers. This is the institutionalization. Don't be so schematic to think that the institutionalization is opening the door and pushing out patients. That's unrealistic. The critical point is to prevent new entrants. Italian reform was successful because the reform was stopping the entrance door, was not pushing out. To push out the population of the psychiatric hospital, Basaglia, took 17 years. So the first day of the reform, no new patients came into the hospital. The population that at the time was 700 patients of the hospital was reduced along 17 years of action. So the urgency is closing the entrance door, is not opening the exit door. The rational deinstitutionalization is having three programs. The program increasing out, the program stopping in and the program improving stay for those. We are using this model in many Latin American countries nowadays. I am personally working for the World Health Organization in Jamaica, in Dominican Republic, in Paraguay, and we are getting a lot of success because ministers are not panicking. You are not going to the minister and say, hey, sir, now you have to close down your psychiatric hospitals. The guy will say, no, thank you. Antibodies, you are dead. You are completely dead. If you start your idea of deinstitutionalization, asking the minister to push out 600 patients. The problem is where we have enough community mental health service, a good catchment area, we have enough general hospital beds for acute. From those areas, no more admission in psychiatric hospital. So you decrease by 10, by 20, by 25% new admission. Second year, you have another catchment area. You have created another community mental health service, and you have created other beds in general hospital, and you are decreasing by another 20%. So across the time, so the minister is not panicking because you are slowly preventing new admission and slowly promoting the hospitalization of those who are in hospital. You have the UN Convention, where physical and mental disability are together, which says that disability per se cannot be used as a reason for limiting freedom. Nothing about me without me is the slogan of users today in Europe. Now you have to ask yourself, how much about them is done by you without them? So there is a lot. It is not true that we are so good that nothing about me, the user, without me is a reality. There is too much that we do without the say, the opinion, the power, the presence of users. I will end my presentation trying to respond to the first preliminary question I ask you and myself. The notion of community that we use and use and use, using this word every day in many instances. Are we sure that community exists as we have imagined during the last 100 years? What is the community we have in mind? Something that I call a rural romantic idea of community. A center where there's a place, there is the pharmacist, the doctor with a white beard, very nice, and there are the people talking to each other, there is the bar, there is the taverna, and this community exists probably in some remote rural village of Greece. The reality of community is that community today is much more than a geographical space. Community in the past was something about contiguity between people. You and me are neighbor. This is the community. Now, people operate in virtual community. There is more community if you belong to the same Facebook group or Instagram group or the same football group or the same basket group or the same tribal group, ethnic group, which has nothing to do with the geography of the community. Now the community is virtual from the geographical point of view. And we have to rethink the idea that which is very old and very traditional, of community we have in mind, because we still believe that being into the community geographically is enough. But if you want to work with young people, their community is not geographical. You have to step into other virtual community. All this requires a lot of rethinking, a lot of theoretical work, and a lot of philosophical rethinking. The second question was, is psychiatry the same as mental level? No. No, don't use this as synonymous. Psychiatry is a relatively small component of mental health. And when we talk about psychiatry too much, we risk to forget the possibility of an action having an impact on social determinants. Only if we talk about mental health, we encompass the biological, the psychological, and the social determinants, not simply as a etiological model. Today, nobody is so stupid not to think that mental disorders are biopsychosocial. That we are saying this since 50 years. This is trivial, it's banal. The problem is not if you think that mental disorders are determined by biopsychosocial determinants, but if you do in your service intervention that are bio, psycho, and social. Because too often you think that mental disorders are biopsychosocially determined, but your action is purely biologically formed, biomedically based, or psychologically based, or biomedical and psychological based, but not enough socially and social intervention based. So the advantage of being very old, like I am as a speaker, is that these two challenges should be addressed in the future by you and not by me. That's very reassuring for me, because they are terrible challenge. Good luck. Try to respond to these two key questions in your future actions. Thank you very much for your attention.
Thank you. Hello. Thank you so much, Benedetto, for this excellent presentation, raising really key issues, global key issues for mental health, which are very relevant also for the Greek reality. I think for any reality, because what you address in your presentations are the components of a better mental health that we are looking forward to realize in the whole world and also in our country. Allowed me to focus a little bit on the Greek reality, taking advantage of your observations, of your remarks, and of your ideas, and also of your global experience around the world. The first issue I want to raise is a political and institutional issue concerning the Greek reality. I'm involved in psychiatric reform in Greece, as you know, and the other colleagues know, from 1986 in Greece. I think the reform in Greece is advancing only through crisis. In 1988, when we had also your support in the LEROS deinstitutionalization program, you were working in this period in Istituto Mario Negri in Milano, we had the crisis of LEROS. What does it mean, crisis for Greece? It means that the whole country was totally stigmatized by the violence and the abandonment of a remote psychiatric hospital, asylum, in the island of Leros, which, as you know very well, served also as institution and buildings. We use the buildings of the Italian Navy, when the Decanese belonged to Italy. So first crisis was Leros, and we did some things, some programs about deinstitutionalization without enlarging the notion of deinstitutionalization as you have defined it before in your speech in the other asylums. Second crisis was the earthquake of Athens in 1999, where a lot of buildings of Dromokaition, one hospital, and Daphne, the other asylum in Athens, were destroyed. So a large program funded by the EU was launched in order to deserve the patients that were hospitalized in the asylums, but without integrating a whole system of catchment areas, sectorizations, and continuity of care through mental health facilities, and also the creation of psychiatric wards, psychiatric departments in general hospital. The third crisis, and this is our third occasion now, is the pandemic and the end of pandemic. Through the third crisis, we have the opportunity, and probably is with us, Professor Nikos Stefanis, who launched the program in Greece of early psychosis intervention, and will be delighted to take the floor after some remarks and enrich our debate. So we have an occasion now, an opportunity, a political, institutional, budget opportunity to found these new community mental health facilities and settings in order to deserve the young people, to prevent the admissions in psychiatric hospital, and to avoid remissions for young people. 3,000 people all around Greece are entering, let's say, in the schizophrenic process to avoid the career of schizophrenic in psychiatric institutions. Fine. Two remarks about all these introductive, let's say, observations. First, in Greece, there is a huge lack of continuation of administration, of institutional actions, of political actions, in order to continue and to integrate each reform and to fund, to have consistent funding in all these reforms. So if we have this continuation, you can imagine that to address the social determinants of mental health, such as poverty, immigration, conflicts, violence, which all have increased during pandemic, is much, much difficult. Second remark, despite the fact that we have received funding from EU to develop community mental health services and to close down all our psychiatric hospitals, mental health hospitals, psychiatric hospitals, we have still a parallel system in Greece. A parallel system created by, from one hand, community mental health services provided by NGOs, by the national health system, by security system, small experience of local municipalities, and from the other hand, we have still the terminal, the two asylums remaining in Athens and one asylum remaining in Thessaloniki, which for the moment are untouched we can understand why they are untouched, but there is not in the political agenda the project to close down those hospitals for this moment due to socio-economic crisis, due to pandemic, due to the actual Ukraine war. So how can we deal with this parallel system? First question. Second question, how can we deal with the training and the supervision, as you mentioned, not only of GPs, of general practitioners, of general doctors, but of psychiatrists and psychologists who, from the one hand, they use biomedical model, so they are unable to discern the holistic approach needed for our users. And second, psychologists, for instance, who they use their psychotherapeutic techniques independently of the biopsychosocial approach, which might be holistic and effective. So second question is the training. And the third question is the question you raised about rights of users and mental health democracy. As you know, we have signed, as Greece, the CRPD Convention, United Nations Convention, but we have a strong evidence and indicator that the rights of our users are continuously violated through two strong indicators. We have published in this issue, and there is strong evidence. First, more than 56% in general of the psychiatric admissions in Greece are involuntary admissions. Involuntary admissions in psychiatric hospitals, the three remaining, and also in psychiatric wards in general hospitals. So discontinuity of care and fragmentation of the system. Second strong evidence, 1 to 4 to patient who is hospitalized, the involuntary admission is submitted in coercive measures, mechanical restraint, and of course, measures who limit the dignity of the person. I stop here in order to open the discussion, and I look forward from the other colleagues and friends to take the floor, to raise hands after your first reaction in my questions, in order to have a rich and fruitful debate today. Thank you. So Benedetto, the floor is yours for the moment. And after we're waiting for the reactions of the audience and...
No, okay, thank you. I will speak 2 minutes because I think it's more important to listen to the colleagues. I think that there is no solution, quick solution to the problems you raised, because the problem you raised are a complex, interlinked dimensions that have to do with at least 5 dimensions. And you have to operate in those 5 dimensions. Number 1, education. You should educate. Educate whom? The politicians.
Yes.
The family members.
Yes.
Society at large. Staff about technical issues. You mentioned that Professor Stefanis, I was a good friend of your father, Professor Stefanis. I remember a very nice invitation to the Parliament of Athens done by your father, who allowed me to speak, and we had a nice dinner. So we have a nice relationship. So I have a very good memory of your father. But you mentioned, Stylianidis, the fact that Professor Stefanis is introducing, is mainstreaming the early
psychosis intervention.
The model of McGorry in Australia and so on. This is something very important. This is a key element that may improve substantially the way mental health services operate. So education means training. Education in social determinants, education in technical issues like early detection or in social issues. Education of family, increasing their capacity of understanding beyond their own personal problem, not being prisoner, hostage of their narrow myopia of their problem. Training, educating politicians. I mean, as you did when the vice minister visited your center, that means educating the minister, because the salutation of today of the minister, someone prepare her speech, but prepare a speech in the right direction. That's a good education. And then that's one dimension. Number two, talking to politicians. Talking to politicians means proposing their concrete solutions. You can't talk to a politician raising a problem. You should bring the politician a concrete solution. That was I learned with my model ideal, that now I have convinced many ministers because I am offering concrete solution to the institution. I'm not doing an ideological discourse. The institutionalization is important. All this means nothing. The minister wants to know what he has to do tomorrow morning, and you have to give him the solution. Third, you should create 1, 2, 3, 4. You remember when we were young, they were saying 1, 2, 3, 4 Vietnam. Well, now what we need is not 1, 2, 3, 4 Vietnam, but 1, 2, 3, 4 best practice of epilepsy across the country. You should become the example of best practice. You should become the model that force the traditional psychiatry to be challenged by the excellency of what you do. And then finally, you should use the UN Convention as a legal instrument. Remember, the difference between signing and ratifying a convention is that the country that signed a convention is saying, fine, I agree with the content of the convention, punto. A country ratifying a convention is saying, I adopt the text of the convention as a law at national level of my country. Greece has ratified. So the convention is not a text, is a law in Greece, is a law. You can put in court whoever in Greece break the convention, because convention for international agreement are like constitutional text. If you change the convention, it's like changing the constitution. You don't change easily the constitution, you don't change the convention. You change the national law. So you have to use more proactively the convention as an instrument to impose that the views that you and I and we all here have are not our personal opinion, are now regulated by law and not by choice. Psychiatrists, traditional psychiatrists, tend to believe that what you think, what epilepsy thinks, is an opinion. Now, it's more than opinion. It's an evidence-based opinion regulated by norms and international laws. So you have power. I stop here.
Yes, thank you. Thank you, Benedetto, for your prompt response. I would like to ask kindly to Nico Stefanis to take the floor, open his camera. And Nico, are you with us?
Yes.
I hope so.
Okay, please, you have the floor.
I hope so. Well, what can I say? First of all, it was just a beautiful speech. I really want to generally congratulate you. These are not the speeches we hear in our big scientific, academic, psychiatric meetings. It is so refreshing to hear this alternative talk about how things are and where we should be going. I was thinking, it's also great to meet you personally through this vehicle. I always wanted to meet you and have some sort of discussion about what there is to come in Greece, because in many ways we feel that we are in a crossroad in many ways. I will look at the more optimistic side of things. I will say that it's the first time that I feel that, you know, coming from a very academic background myself, Institute of Psychiatry training, Australian, that I've had my own internal questions answered through the reaching out to the community principles. And a small indication of that is what, after, I would say, about 6 or 7 years of lobbying the governments, the previous governments, the current government, it's the first time that we feel that there is an opening in mentality, and that we have the political clouds behind us, and we have the money, to be honest, to start and think of a much more community-based psychiatry, meeting the needs of our young people who suffer for the first time of the most serious mental illnesses. It's a first glimpse. In many ways, I feel we have a Greek expression here that I feel like a fly in the milk, in the sense that it feels like a process that we're moving forward in almost in isolation, intending and building up this community-based mental health services for young people. And it's difficult, and all the obstacles that you mentioned are in front of us now, but the momentum is probably building up slowly. The resistance is already there. It's detectable. They are exactly the way you described them. They are going to be. We anticipate this resistance, but I'm sure that a large proportion of my colleagues share these common values and share this understanding that there should be a change in the way we perceive help for people in need. And that there's only one way forward, and that is towards the community and inventing probably local solutions to help people in great need. So it's a first step that's taking place now. The government has declared, I had to go to the Greek parliament. I never did that in my life. I did that yesterday. And presented the arguments about why we should open up to following as you mentioned, the early intervention movement, why we should follow that route for our young patients who suffer the most and have the least support, to be honest. And we secured a parliamentary kind of seal of approval by all political parties. And we secured that at least a substantial amount of money will be given to these early intervention services across Greece. They will be developed. We are in the process of the bidding, essentially, this week. We expect that the government will announce officially the bid for the first community-based services within the next few weeks. So it feels honestly like we are in this transition phase where things might be changing towards the better. I'll just say that. I'll just say how much I genuinely enjoyed your talk, and I hope to meet you personally at some point. You mentioned my father.
We will.
Yeah.
Yes.
And it'd be great to meet you in person at some point in the near future, actually.
I would like very much, sir. It will happen soon.
Nico, thank you very much for your intervention and also for your comments and your presence yesterday in the Parliament. It was very crucial to go on and to continue to implement these pilot services, the best practices as mentioned by Benedetto. So please, I ask to any colleague to take the floor, raise hand, and ask questions or comments or whatever you would like to comment on this very rich presentation. Don't hesitate. I think Nikos, okay, Nikos Gionakis is with us this morning. Nikos? If Nikos is with us, yes, can you open the camera, please?
It is on.
Okay, good morning. I would like to ask you how you can apply those principles and guidelines mentioned by Benedetto Saraceno in his presentation in your work with refugees and migrants in Greece. For instance, if it makes any sense to you to comment and raise this issue in your specific work, which is very important since many years, since 15 years, I think you are working in this field. So yeah, Nico, you have the floor.
Yeah, thank you. I'd rather like to comment on things that he didn't say today, but he has written, for example, in his book about global mental health, a critical approach to global mental health that he wrote some years ago, and it's very, how to say, important for me because it brings some different ideas about what is global mental health and how we can work with people who come from different cultural backgrounds. And this is something that I'd like him to comment, Benedetto. I mean, that when we speak about global mental health, we must be very careful not to try to how to say, to expand the Western model all over the world, because this is now what he says that we are trying to do in a certain way. For example, to sell medication, the same medication all over the world. And this is something that is really very, very dangerous. Working with migrants and refugees, these last 15 years, personally, I have understood how important it is to get rid, if you like, of certain ideas that are spread traditionally. For example, about the role of diagnosis, or what means when we say psychosocial rehabilitation. For example, Benedetto says that, and he mentioned this today, that psychosocial rehabilitation is not something that has to do with the acquisition of skills, of abilities by people in order to be able to get adapted to a given society, but to speak about social inclusion, that is a dual, let's say, process to work with the individual, but at the same time with the environment. And this reminds me the common statement between WAPR, the World Association of Psychosocial Rehabilitation, and WHO in 1995, that was presented at the Rotterdam Congress of WAPR, and it was stating something like that. And how important it is to work at different levels, from education of politicians, families, and so on, but also how important it is to train ourselves, how important it is to speak about social inclusion, not as a unidimensional or unidirectional approach, but to work at different levels. How important it is to, how to say, to speak not about only needs as we perceive them, but as people perceive them. And not only about their needs, but also about their abilities that they still have and their capacities, and how to use them, to exploit, if you like them. It's not a good term, but this is what I can find now, for people to educate us about how to survive. And especially with refugees, this is something very important, because they are not victims, they have survived and they managed to still survive in very adverse conditions when they are here in Europe. They come here in Europe, and they have so many things to teach to us about how to survive in crisis, adverse conditions, and so on. So in a certain way, how to approach them as individuals that are as subjects of their own history and of their own, they can control their own lives. And it's not us that we will substitute their abilities with ours. And so many other things that he has mentioned. And they, of course, they are applied in what we do, working also with refugees and migrants. And he mentioned as an example the fact that, I don't remember now where, the services offer to people with mental problems mobile phones to communicate. For example, this is something that we do since many years, as to offer to people that we follow and we take in charge and we try to support mobile phones and to pay for their cards in order to be able not only to communicate with us, and especially during the lockdowns because of the pandemic, but also for them to be able to communicate with other people, thus enhancing their potential to be part of community networks. And this is psychosocial rehabilitation, for example, this is inclusion, not because you have better skills, but because you are part of networks. And this is something that we try to do. And there are so many other things, but it's okay.
Okay. Thank you, Nikos, for your comments and questions raised. Benedetto, would you like to comment on these issues raised by Nikos, or?
No, simply saying that he's right. Global mental health is a very ambiguous expression. Mm-hmm. I'm afraid that majority of people think that global mental health is export of Western model to the rest of the world, which is nothing to do with global. This is Westernizing the world, which is different from a global mental health. I would say that global mental health is global only if it is local. I don't like the expression global mental health. I don't believe that we have a global mental health. We have many local mental health. And I think that every local mental health may enrich itself from some Western psychiatric knowledge, no doubt, but also from other knowledge. I am afraid that the model, there are things that are not necessarily Western, like capacity of listening, capacity of recognizing that people are producing meaning when they are suffering. This is the only way we can operate or work with immigrants, for instance, or people coming from different cultures, essentially not pretending that we have the solution, but having the capacity of listening to and of recognizing the value of meaning of their own personal history. All this has nothing to do with global mental health, has to do with good mental health. And global mental health not necessarily is the good mental health. So I'm not playing with the words, but I think that we have to look with some caution the notion of global mental health, because too often it means simply that the London Institute of Psychiatry, King's College, or the Harvard Institute of Mental Health, or the Australian Melbourne Institute of Mental Health are exporting their own models to the rest of the world. This is not global mental health. This is knowledge transfer. And knowledge transfer sometimes transfers also bad things and not only good things. Because let's remember that psychiatric institutions have been invented by the European. So let's not export once again something wrong.
Mm-hmm. Yeah, absolutely right. Is there another question? Nikos, please.
I have a question.
Please.
Thinking positively about the future, we know that there is a World Health Organization outpost here in Greece. We know that the Ministry of Health has been in not only discussing, but there is an establishment of that institution over here. I was wondering if this is a vehicle, of communication that we can develop in order to expand these efforts that we have started in many ways. How does the WHO, how could you think of the WHO would participate in our efforts to make things better over here?
My impression is that the outpost of WHO today in Greece is more concerned with a general issue of quality of care, more than specifically on mental health issues. WHO has two places where you should look for collaboration. One, of course, is headquarters in Geneva. And now headquarters in Geneva, they have a special initiative on mental health, which is targeting a number of countries. Greece is not part of those countries. And they are launching in the next 2 or 3 weeks the new World Mental Health Report, which will be full of recommendations for high and middle income countries like Greece is. But the real collaboration should be established with Copenhagen. Copenhagen is the site of the European Office of Health of WHO, where there is a specific officer in charge of mental health. This person is now developing a European Alliance for Mental Health, which is a very important instrument to network mental health best experience and best practice across Europe. So my suggestion is, more than addressing Geneva headquarters, addressing Copenhagen, where there is an ad hoc mental health. Is a psychiatrist, is a woman, is a lady, and she is in charge of the mental health program, and she has some staff, and she has some funds, and she has some strategic ideas. I am sure that if you take an appointment and you go to Copenhagen to discuss action, collaboration between WHO, you may be extremely powerful when you are talking to politicians, if you are talking with under the umbrella of the World Health Organization, the European office. So my suggestion is to talk to the European office in Copenhagen.
Thank you very much.
Yeah.
Although I think we should be talking to our colleagues first. I mean,
Yes.
there's a lot to talk to them about, and as you very well mentioned, the principles, for example, of working in a multidisciplinary team, even simple things that we've been accustomed working elsewhere, are not understood very well over here, for example. And let me share this kind of anxiety I have about the whole thing. And it seems that we are producing a model, for example, of care by these new initiatives, but in an environment that does not provide the kind of support that they should. The social services are not accustomed to working, for example, the community. The colleagues are not very well educated into working in a multidisciplinary fashion. I can go on and on and on about the potential problems and resistance that one faces when he wants to open services to the community in a much more productive way. But I suppose we'll face them as they come. Yeah.
My impression is that your efforts about bringing early intervention and the epilepsy model that is now consolidated after so many years, I think you may take the challenge of organizing a Greek conference, international, inviting Pat McGorry, of course, number one, inviting 2 or 3 senior international, highly reputed experts that are coming to, in a way, to support, to endorse epilepsy model, to invite the politicians, and in a way to challenge the most resistant and traditional environment of psychiatry that resists to technical innovation, like is your case, or innovation in general of the services. I think after so many years of existence, you, epilepsy, you, Professor Stefanis, all you together, you have enough weight, prestige, visibility, international credibility to organize, even in a very, I mean, not rich, you are not organizing those traditional things with big dinner or paying a business class. You are doing in a frame of poverty because you are committed to the public mental health. And I think with not very much money, asking the support of few people, key people that will willing to help you, and inviting, that's fundamental, Dr. Lydia Lazzari, who is the name of the psychiatrist in charge of mental health at the European office in Copenhagen, Lydia Lazzari.
From Albania, no? From Albania.
She's Albanian by nationality.
Yes.
She's very international because she speaks a wonderful British accent, and she's much more international than Albanian. But anyway, she's competent and she's knowledgeable. And she's surrounded by a person like Dan Chisholm, who is a mental health economist, and mental health economist that has calculated how better is community mental health than hospital-based mental health, proving also the economic aspects of the two models. So you have to be strategic and to invite not many, 2 or 3 or 4 key people, Chisholm, Lazzari from Copenhagen, McGorry from Australia, another couple of people from your friend countries, by Barbato from Marionette, I'm inventing, I will help you. I don't want to be invited. I will come because I have a house in Sifnos, so I will use as an excuse.
Can I just answer to that? Because
Yes.
This is a direct response to what you just mentioned. I'm very happy to tell you that in the next month, that is the end of June, I'm the president of the World Psychiatric Association meeting that is devoted to early intervention. It will take place in Athens. Pat McGorry, Jim Vanos, Robin Murray, all the people who were my mentors throughout the years and also have really very strong views about early intervention, will take place in Athens next month, and I can't wait to meet them all. We are working towards exactly bringing in Athens, bringing to Greece, the model and the prestigious people who would support this type of reform that we're talking about. So I'm very happy to respond to that.
In some way, that's fantastic. I didn't know that. But what I'm suggesting is a more public health conference. So probably less scientifically oriented and more public health oriented, more health system oriented, which should include the scientific component. That's the reason I was mentioning Pat McGorry, but should include also an assessment and analysis of the public mental health system of Greece today, with some kind of challenges to the politicians. Yes. So I think that the conference you mentioned is very important, but probably is too sophisticated thinking to what I have in mind, which is more political and less science-driven.
Okay, thank you, Benedetto, for your suggestion. I think we can plan this event in the near future with Nikos Stefanis and the other colleagues. Thank you. Alexandra Pali, psychologist, raised her hand. Please, Alexandra, the floor is yours.
Yes. Hello. I just wanted to, we're talking about strategy now and how to build services and early intervention in psychosis. I just wanted to comment on this comprehensive speech we had the chance to hear, and to stay on 2-3 points which I found very important, and I think they contribute to the creation of services and to the communication of new services or of older services with the communities. And I think one important thing I've heard, it was that we cannot really have prevention in more mental disorders, but what we can do, we can prevent relapses. And I think that is a very important message to be spread in the community, that the people, the families, the patients, the politicians, and generally the community get the meaning that, get the idea that we are not helpless, but we can do things and we can prevent relapses. And then I found important the call that Professor Saraceno said to create good practices and to focus on good practices on services. And I was thinking, playing with words like he amazingly does, maybe the idea could be not to create, not to import good services, good practices in a service, but to create a good practices service. On the other way, to start with good practices and to build around good practices service. And the third thing that I found important was that the point which he wrote about virtual community and how virtual community works. And I think it's a very important dimension at the moment to think and to focus on how we can profit from virtual community to achieve psychosocial rehabilitation or any other goals we are intending to. By this chance, I would also say that with WOPR, where I am very active at the moment, we are planning, and we had a decision in our board, in the local board, to have a congress in Athens in September, and a congress on good practices of psychosocial rehabilitation. And maybe in this more political or in more open idea that Professor Saraceno said, and I hope we'll have the chance to discuss with Professor Stefanis and Professor Stylianidis about. Thank you.
Okay, thank you, Alexandra. I think we have, you have raised an important issue, also underlined, highlighted by Benedetto before. In all European countries, there are good practices which still are not theorized. They don't produce, for the moment, great evidence. So we have to respond to this challenge in how to produce evidence and political and social visibility with our good practices. There are islands in Greece that produce good practice, and renew, address the challenge to politicians. This is a very concrete task in the near future. The time is running out, so I would like some conclusive comments before Benedetto leaves us in our meeting. I don't know, would you like to, because we have to finish to close up the meeting, would you like to say a final word, Benedetto, before to tell you?
Words. Thank you for inviting me, and good luck, because you have big challenges in front of you, but I tend to share the optimism of Professor Stefanis. I think that you have reached enough critical mass of knowledge and experience to play a role for improving mental health in Greece. I think that's not rhetoric, not something that I once say to be nice at the end of a conference. I have this opinion, and I am prepared to be at your side as a friend in the future efforts you will do. Thank you very much.
Thank you so much, Benedetto. We have a lot of work to do, but your support is very, very precious and helpful. Thank you, everybody. Αγαπητοί συνάδελφοι, ευχαριστούμε πάρα πολύ τους συναδέλφους.
Thank you, Mr. Saraceno.
Thank you.
Thank you.
And hope see you soon. Bye-bye. Thank you.
Thank you.
Bye-bye. Thank you so much.
Good.